So this patient's coming in for removal of a lesion. How long's it been there again for you?
About 3 weeks.
So it's growing relatively rapidly. This is behind his left ear. You can see this is sort of a pearlescent in appearance. It's really quite tender. It's tender enough that I'm going to use a topical anesthetic first. There's limitations just in terms of how well these work. A little cold. You okay there? Good. So I'm working with Dr. Jane again. So what do you think of this lesion, Dr. Jane?
It looks, Stephen told me that it was a basal cell.
Suspicious for it, right? So there's essentially 3 cell types of the skin. There's melanocytes, there's basal cells, and there's squamous cells. Little poke here. So oddly enough, what are the 3 cancer types that we see? Basal cell cancer, squamous cell cancer.
And melanoma.
Yeah, melanoma, right? So now there's a 4th one. You remember what that one is? It's much more rare.
Bowen's.
Bowen's is a subset of squamous, but that's a good one. So there's also a Merkel cell cancer that's more rare. Now you also get into, are you okay with that? It's not hurting too much?
No.
That's pretty good. So in this case, the topical actually worked pretty well for him. Those are much more rare. And then you get into like other cancers that can have skin manifestations, Kaposi sarcoma, things of that nature. Now the other one you have to worry about here, there's something called a keratoacanthoma, which they think is a variant of a squamous cell that can look like this, or that sort of rodent ulcer in the middle of it, they talk about that erosive ulcer in the middle of it, and that would be a concern here. So essentially what we're going to be doing is, once we freeze this, we're going to just do a shave, and then we're going to be cauterizing this. If we're fortunate it's more of a basal cell cancer, then a lot of times that's the extent of the treatment. This is just a buzzing. You'll hear. So does that hurt when I do that?
No.
So he was, prior to this, when we were just touching it, he was wincing, so this was pretty uncomfortable for him. Yeah, sort of consistent, it's not coming off for him. So this is our number 15 blade again. Essentially I want to be shaving this right up against the skin. Now any of these diagnoses that we're entertaining have typically a big blood supply. Just going to hear buzzing again, recauterizing this. So the one thing I should mention here is when you're cauterizing normal tissue, it'll almost create almost like a sandpaper grit, and it'll be pretty dry right away. When you're dealing with neoplastic or viral tissue, the tissue tends to weep or emulsify. See how that's emulsifying? That's because it's atypical tissue that's there. So essentially what we want to be doing is we want to be cauterizing. That's not uncomfortable for you?
No.
Good. We want to be, see how that's just emulsifying there? That's because that's abnormal tissue. And that's what we end up getting on the cautery unit. So we want to be cauterizing through that. So essentially once I get a cautery bed on this, I'll use the scalpel and just scrape that a little bit. See how that's cauterizing differently right there? That's what normal tissue looks like when that happens. So essentially we want the whole field to be doing that. So once I've done that, I'll just take my number 15 blade, and again, I'm just going to scrape off this extra tissue that's there, which seems counterintuitive, because you're like, oh, it's going to open back up and weep again. But I want to clear that atypical tissue, because the more of this, if we can get it right down to normal skin, this might be the end of this procedure, especially if it comes back as just a basal cell cancer, because those will actually heal nicely. What's the metastatic rate of basal cell cancers? Do you remember?
It's like 0.1 or something.
Yeah, it's even, so it's less than 0.05% typically. So this is why in the past, like the more advanced procedure we do now is something called a Mohs procedure, where essentially what they're doing is they're taking a layer, then they're analyzing it, and taking a layer until they get down to normal tissue. But prior to that, like we would even take this, 10, 12 years ago, all they would do was scrape them off until they were content with the fact that they were deep enough. And then if the tissue came back normal, like grew back normal, they didn't do anything further. But if they had any abnormal growth, then they would sort of shave down some more tissue.
In this case, if the
See how that's cauterizing differently?
If the histology came back and it was still like, it didn't look like you had clear margins, would you go back and do that?
Yeah, so for basal cells, I may not. So depending on, because again, you're not going to get margins with this because we didn't. So while we submitted the initial sample, we know there's going to be some cancers at the edges because just the way this is acting. You know, the fact that I have this abnormal tissue that's there is going to show me that there is some tissue underneath it, which is what we're scraping off now. But certainly if we get anything beyond that, then we'll have to go in. The two that would precipitate is not having to do much is if it's a basal cell cancer or a keratoacanthoma, and this heals completely normally. So it's right down to normal tissue. You couldn't tell he had anything done. Then we're likely going to be finished with that. But if he has anything beyond that, then we're going to have to do something extra. So even though a lot of times by the same process, if I take a squamous cell cancer down to this level, sorry, I'll avoid that spot. So that's just getting deeper, and we're starting to approach some cartilage that's there, so that's why I'm going to avoid that area. That's what that discolor is through there. And that part's not frozen as well. Doesn't hurt when I'm doing it over this side? No. And that looks pretty good. So this, we'll just want to allow that to heal back in for us, and then we'll sort of see what that looks like. Good. So this is follow-up of a skin lesion we took from behind his ear. Two reasons to sort of take a look at this one. This one we sort of ran into a little bit of cartilage. You can see how it's sealing over from that perspective. And otherwise it's drying out nicely. So this is about, how far out are we now? A week and a half, 2 weeks?
No, two weeks and 5 days.
Yeah, so not too bad from that perspective. This did come back as a positive for squamous cell cancer, so we're gonna have a little bit of follow-up done with that, but this is healing appropriately for now.